hit a truck. Someone was crossing tracks.
An Amtrak train knocked off the tracks and off the rails moments after hitting a dump truck in Mendon, Missouri, in the middle of a cornfield. 7 cars derailed with hundreds of people inside. 4 died, more than 150 others are injured, some critically. It's a mass casualty event that triggered teams of emergency responders into action. We'll talk with some of those first-line responders today on Open Mics. Good morning, and thank you for joining us. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System, and we are coming to you live from the Dolph Simons Jr. Broadcast Studio. Passengers told the Sun newspaper they saw several of their fellow passengers and even Amtrak employees severely injured and placed on backboards as they were rushed to hospitals, both near Mendon and here in the metro. Our guest today will help us better understand how patients at a mass casualty event are triaged to receive the urgent care they need. We know the community also plays a role in how emergency responders across cities and states come together for this kind of event. Start sending us your questions and comments now on YouTube, Facebook, Twitter, and the Medical News Network. The links are right here on your screen. From the hundreds of units of blood possibly needed to all the extra room and staff for those hurt, hospitals have a plan in place and work with organizations like the Mid-America Regional Council, we call it MARC, to make sure everyone is treated. Joining us today are 3 of our outstanding physicians who practice in either emergency room or trauma and who hold titles here at the health system. Dr. Robert Winfield is the Division Chief for Acute Care, Surgery, Trauma, and Surgical Critical Care. He's kind of like the medical director of the whole trauma program. Dr. Brian Beaver, the Fellowship Director for our Emergency Medical Services Disaster Medicine. That's for events like this. And Dr. Ryan Jacobson, who's the Medical Director of the Johnson County EMS and also one of our medical ER docs. Joining us virtually are Lee Summit's Fire Chief, Assistant Fire Chief Dan Manley, who is also co-chair of MARC Emergency Response, and Matt Dougherty, Director of Business Development for Lifelight here in the Metro. But we start with 2 survivors of the Amtrak derailment, siblings Dax and Samantha McDonald. Samantha's a pre-med student at the University of Arizona. You were taken to Moberly for a CT scan. How are you both feeling today? Let's start, Samantha, with you.
Good morning. Yes, I was. So when the crash happened, I was on the left side of the train car that we were in, and I was thrown to the other side of the train car, hitting my head and scraping my face and hitting the right side of my body against the train car. So because of that, I was bleeding from the right side of my head and from my face. So I was put into a triage group. So they had 3 different groups. So it was really well organized. And I was put into yellow at first, and then we were put onto a bus to Moberly Regional Hospital, actually. And when we got there, I was given like a triage card. I think that's used in natural disasters you guys are probably familiar with. And it had like a red tag on it for immediate. And I was sent to a CT scan. And then I got x-rays as well for my knee. But everything cleared up. Everything's like, I'm okay, obviously, but just a little banged up. But
You're a little shook up, and with no shock to that. So, okay, first, I'm just glad you're here because that's a close brush when you get hit in the head like that. Did you have a concussion from it?
I didn't, actually.
Good. Well, that is a good thing. And you and I were talking before the show a long time ago, Samantha, in a land far, far away, like in 1982 and 3, and for a little longer, I was actually worked at Moberly Regional Medical Center as a unit secretary trying to pay my way for medical school. So, Dax, talk to us a little bit. How are you doing?
I had no injuries. I was on the right side of the train. I kind of also saw the like the dust cloud basically of the first kind of trucks as they were, running perpendicular to the train. I kind of in my head I was just thinking that's kind of odd that there's these two large dump trucks moving kind of quickly perpendicular to the train. And that's when I heard the first bang, and I was like, "Oh, we've definitely hit something." But I honestly thought at first it was just be a large delay. I've heard of trains hitting cars before, but then when I started to feel the train start to tip, and I saw the car in front of us start to fall over, that's when I kind of knew that this went from like a delay to a life or death situation. Yeah.
Man, that has to be scary because you're watching it happen. Then you feel the trip and the tip, and you're thinking, okay, am I going to get out of this alive? What do you recall about being rescued from the train?
So yeah, I think that first video I took was immediately after. We like kind of stood up and like everyone was calling out to see if everyone was okay. There were quite a few older people on the train who were, facing on a move, or I think I broke my arm. The person directly in front of us was actually having a seizure. I think, partially because of how she, again, if you're on the left side of the train, like my sister, you were thrown and you very likely to hit your head. So, that person was kind of getting stable. I was looking I was like, okay, how are we gonna get out of here? The only thing we kind of realized is that both exits on the front and back of the train were, those weren't usable anymore. The only real exit that was possible after a while, we realized was directly straight up from us. So it was like a 10-foot directly above us was the only way out through formerly the left side of the train, now the roof, through the windows there. That was, and I think that basically some people started opening those windows and started essentially, if they were able to, making the climb out. And that's basically what we started to do. People started saying, anyone who can get out, let's help lift you out. So that's basically, we walked over there, or kind of got over there and got to one of the windows that was open. And then basically survivors who are already out started helping pull people out. And that's kind of, that's how we got out. I was traveling with my two sisters. So there's another sister, Sheely, and our mom was actually in a different car and in the restroom, who also managed to get out earlier and was on the roof of the car and was yelling down and checking every single car to see which car we were in. And that's when we heard her, and she's like, she really wanted us to get out of the car. So that's how we kind of
your whole
got
family.
on top.
Is everybody okay in your family? Your other sister and your mom, they're okay too?
Yes, there. Yeah.
That is a scary. That gives me the chills here. Chief Manley, tell us about getting the call Monday, and how emergency responders everywhere were notified about that.
Thank you for the opportunity to be here today. The first call I received on the incident was about 1:12 in the afternoon, and it was from Assistant Chief Jimmy Walker with Kansas City Fire Department. He advised they'd received some information about a derailment north of Kansas City, and he advised that he had some of his employees that were on the train that were en route to a training event in Chicago. From there, with that information, I reached out to the State Mutual Aid Coordinator for Region H, which is in the St. Joseph area of Buchanan County. They covered that area just north of our Missouri Region A, to see if they had any information about the derailment. And at the same time, I also reached out to the state Department of Public Safety to be able to advise of the information we'd received on the derailment. From there, I began to secure resources that could be available to respond. Kansas City, Missouri Fire Department has their technical rescue capability that were rostered and ready to deploy at that time. Also began to put together mutual aid ambulance strike teams from Region A that would be available to deploy. It was about 15 minutes after that we received information that the derailment was in Mendon, Missouri. And so we focused on being able to roster resources closer to the event and assist with the management of the scene. the mutual aid coordinator from Region H and then Region B, which is where Menden is located, deployed to the scene, and then we're managing resources on site for the event.
So Matt, you work for Lifelight, the emergency helicopters that flew patients to hospitals. We heard at one point that 25 helicopters flew to the scene, part of a mass response inspired by the Joplin tornado of 2011. Explain to us how all that came together.
Good morning. Thank you again for the opportunity to be here. I think our number was probably closer to 16 is what we are estimating. Some of those helicopters eventually was determined by the commanders on scene were not required. And so I think we ended up with 11 helicopters total that actually responded to the scene, which is still the 16 helicopters on their way is more than half of the medical helicopters in the state of Missouri heading that direction. So it's a pretty incredible response. And as Chief Manley said, the ground agencies that were responding from everywhere, this is a tiny community in a very, very rural area. Many of the first responders were volunteer fire departments. So they were leaving their day jobs, leaving work to come to that. And so it was a very impressive response by those rural agencies. Our Chillicothe helicopter, Chillicothe-based helicopter, was the first on scene. We were dispatched called by Chariton County 911, and we received that initial call at 1:02, and were able to be there in about 20 minutes on scene as the first helicopter. And then our pilot helped to land the additional helicopters, providing some of the air-to-air communication or air-to-ground communication coordination with that, while our crews jumped in and helped with some of the initial triage and then began providing care for some of the most critically injured patients.
Yeah, that is, it's impressive to me, Dr. Jacobson, that EMS can mobilize and respond so rapidly. Talk to us a little bit. How does that happen?
Yeah, so this particular instance, fortunately it didn't impact the Kansas side of the region too severely, but preparing for a large amount of staff needed potentially. So taking stock of what we have available for resources, because we have mutual aid agreements in the region, and if called, we'd always like to be able to respond. So one of the things is potentially doing selective callbacks and trying to get more employees to come in, because as you know, we're required to maintain 911 response locally, and when you have to go outside of your jurisdiction, that definitely puts a burden on the local 911 to still have the call answered. So a lot of times we need to worry about staffing up. So people would be called in to try to do overtime and try to get other reserve units put into service so that we can go respond outside of our local response jurisdiction.
It takes a big village to respond like this, and we talk about a divided America, but when you see things like this happen, you realize at the core, people are here trying to help each other, and it warms your heart just a little bit. You don't want to see disasters, but it is a reminder of some of the essence of who we are. Dr. Winfield, talk to us a little bit about that. Talk to us about how you guys respond to situations like that, and the trauma team, and working with the ER and all these other folks.
Yeah, thank you. Fortunately, when we've thought about these scenarios well ahead of time, and so I work with Dr. Beaver and Dr. Jacobson as well as others in our mass casualty response plans and emergency management plans. But you talk about the threat assessment team. That team is doing exactly what it sounds like, which is they're assessing the situation. They're trying to find out what the total number of casualties are, how that may impact things here in the emergency department and in the hospital and health system overall. And so they are working with the emergency physicians and emergency team to try and move patients out of the emergency department to get them to other care locations if that's appropriate, so that's clearing space for these folks to come in. They're assessing whether or not we have the capacity to take on a number of patients. We're activating additional trauma surgeons if the situation calls for that. And so the team's really trying to take a sort of holistic approach to figuring out what is needed to care for a large number of patients coming very rapidly to the hospital.
It does a team, right? You feel like this is really just an entire team. Dr. Beaver, you are board certified with emergency medicine and EMS disaster medicine. Okay, I'm a former program director. I didn't even know that existed. So help me understand, what is EMS disaster medicine? How does it work in a mass casualty like this?
So in a mass casualty like this, the EMS disaster medicine physician can really fill fill a number of roles. We've got a bit of a unique skill set in that we are trained and comfortable operating in the field and in that environment to maintain and be safe in that environment. That may look a number of different ways. The EMS physician on scene may be assisting in advising the incident commander or the medical section chief. We may be providing advanced procedures that paramedics couldn't, say field amputation for an entrapped victim or something like that. It could also be assisting in the triage of these patients, helping to determine, like our guests talked about, getting changed from yellow to red and deciding who needs to go to the hospital first. Or potentially even at a casualty collection point, we may be able to treat some minor injuries on scene to help keep those from having to go to an emergency department and not tax an already overwhelmed system. And that's what we're excited about our new program to start training physicians for that role.
Yeah, that's a big deal, and we're glad to be doing it, just like I said. All right, we're going to have some more time to talk about some of the injuries and events in just a bit. But first, we're going to turn to our community questions and comments. Jessica Level joins us from Studio B with some of those. Jess.
Hi, Dr. Stites. Good morning. So I do have a question from Amber. She wants to know how the doctors, Matt and Dan personally, how do they deal with tragedies like this?
Matt, Dan?
I think it's very important to acknowledge that first responders on scenes at disasters like this will see things that they can't unsee. And so taking care of our providers, taking care of those first responders with their mental health and providing some resources for them is extremely important. I don't want to go too far down that particular path, but we know that the cumulative effect of seeing these traumas is extremely harmful over time, to the point that EMS has the second highest suicide rate in the nation, aside from veterans. And so we really owe it to ourselves and owe it to the first responders in our communities to provide resources and make sure that we're taking care of those folks, whether it's professional help in terms of people to talk to, as well as peer support programs and things like that through our outreach programs.
Yeah, I love, not love, but it's just so fitting. See things you can't unsee. That's tough. Dan, how about you? How do you guys handle this?
Well, I agree with what Matt had shared as far as the peer support and having mechanisms in place for our personnel to deal with these events. Cumulatively over a career, many things that we've experienced. The best way that I find to deal with that is to be able to go through the debriefing process after action reviews, talking about what we experienced. It helps to develop and mature our coping mechanisms as we move forward. And also identifies times when we may need a little more assistance or support to be able to work to cope with an event. So that's really the mechanisms I find available.
Yeah, good things, right? To have that support, and I mean, you guys got to have that support down for the ER folks too, right? That's a big deal. You guys see a lot of
absolutely.
things.
Yeah, I mean, it's one of those, it's hard to prepare and train for realistic scenarios, specifically a mass casualty incident. You can read about it in textbooks, you can do the incident command training modules, you can do mock scenarios, but until you're really on one of those scenes and you see that and experience it, you really don't know how you're going to respond. So I think that's a real challenge, and I appreciate Matt bringing up the suicide risk in EMS and fire personnel. It's incredibly high.
And Rob, just to say, I mean, you see it, right? Because the people who make it to you as a trauma surgeon, those are the people who have been sometimes injured the most.
Agree, and clearly, whether it's a mass casualty or a shooting on Saturday night, these are life-threatening events, and each one of those does have an impact on our emergency physicians, our trauma surgeons, all the nursing staff, all the ancillary support that we have. And the first thing we do is just ask our partners, are you okay? We, over the last few years, have really recognized the need to be able to step in for someone who may have been affected very deeply by a trauma or by an incident. And so as partners, we look at one another and say, are you okay? Do you need me to step in on your behalf and start taking care of patients so that we can maintain that continuity while allowing our partners the time to recover and decompress from things like this?
Is this part of EMS mass casualty training too?
Absolutely, yes. I mean, we definitely spend time talking with our fellows and helping to develop them to be resilient and to not only take care of their providers, but also to take care of themselves after events like this. And like Rob talked, knowing when they need to step away a little bit to get some help if needed.
Jess.
Jeff would like to know, how do you prepare for mass casualty events like the deadly Amtrak derailment?
That's a great question. I'm wondering the same thing, because do you guys rehearse this? I don't know, Matt, do y'all rehearse this kind of thing? How do you prepare for it? Or Dan, let's start with you.
I would say that we do prepare through training and exercise activities throughout the region. We have a training and exercise group under the Regional Homeland Security Coordinating Committee, and we have a 3-year training calendar where we look at scenario-based activities that help us to be better prepared for events such as this. Specific to an Amtrak event, I know that several agencies across the region have sent personnel down to Texas A&M University for the passenger rail rescue class. I was fortunate to be able to participate in that training program just to learn about different things that are unique to this type of emergency.
Yeah, and Dan, I know you guys have to be doing that as part of Life Flight, because we depend on Life Flight. Every patient as well, how much people depend on Life Flight to get folks to higher levels of care.
Certainly. Air medical programs have, especially this is one of the big learnings that we got out of the Joplin tornado, was how to better use the air ambulance resources. In that case, we had a lot of air ambulances that were available as soon as the storm passed. But in that particular case, there wasn't a whole lot there wasn't as good a coordination among those assets as possible. And that's really valuable, because the air ambulances can get those severe trauma patients to hospitals, to trauma centers much more quickly. And they can also help spread the patients out among multiple hospitals, so that no one facility has the burden of taking care of all of the patients at the same time. And so that was one of the big things that we learned out of Joplin. And as Chief Manley shared and the others shared, we do practice these things. We do tabletop exercises. In some cases, we walk through actual mock incidents to try to help us get better and to plan better. But one of the most important learnings that we can take out of anything is when something happens, the debrief process and learning what went well, what didn't go well, and how can we apply those learnings should something like this ever happen again. Obviously, we're hoping nothing like this would ever happen again, but should it, what lessons can we learn to provide better care for all of our patients?
Yeah. So you guys practice this all the time.
So yeah, I think we're very fortunate here at KU and in Kansas City in general, in that we work very closely with each other within the institution. So I meet every 2 weeks with Dr. Beaver and Dr. Jacobson, and we're going over our mass casualty plan. And to that end, we met yesterday, and we were reviewing what we knew about this mass casualty incident to figure out how we would respond in a similar situation. But again, we've heard from Marker. I think it's an incredible resource. We do the drills every few years, again with DHS, and I think we are as prepared as anybody can be for something like this. So no, we work very closely with one another in these in planning for these events.
And just to say, the Metropolitan Area Regional Council does a remarkable job. It's one of those groups that you don't really hear about it until things are bad, because they're always in the background trying to keep things together and helping us prepare for things are bad. They were wonderful during the COVID response, and then you look at a trauma response and other things that can happen, whether it's mass casualties or disease or whatever. Mark does an amazing job. So, absolutely.
Yeah, I think with the current work group that we have here at KU, the big plan of revising our mass casualty incident plan and making sure that we keep that up to date. That's why we meet so frequently, and it's a multidisciplinary group of the three of us as physicians, plus a couple of other physicians, as well as nursing, emergency management, administrative staff, to be prepared for that. We do trainings here at the medical center as well. We recently did one with our emergency medicine residents, focused on the types of procedures that they would be doing in a mass casualty scenario. So really making sure that that readiness is as up to speed, and we've thought about as many different scenarios and how it may affect us as we possibly can.
Anything else?
Yeah, I think one thing to remember too is with the training, the importance of training to prepare for this is that remember EMS is responding within their own communities. So these are potential family members, these are potential loved ones, colleagues, peers, coworkers. So when you're going into a mass casualty incident, like in Uvalde, those were people that they all knew. And so that adds a layer of injury and a layer of trauma to the responders when they're responding in their communities to their own loved ones and people that they're familiar with. So it really does add a whole layer of challenge for the responders.
All right, we're going to return to COVID question or to this topic in just a moment. I'm going to switch now to Dr. Dana Hawkinson with our COVID count, infectious disease doctor, medical director, infection prevention and control, and all those other words. Hawk.
Yeah, just a quick segue to this. But 17 active infections right now, with 3 in the ICU, 2 on the ventilator, 11 in that recovery period. So our active infections have decreased a little bit, but I think this plays into the conversation that we're having, because if we have these beds taken up with acute COVID, that definitely could affect capacity and affect our ability to treat these actual trauma patients.
Imagine, if something like this had happened when there were 250 COVID patients in the house, and like it was just a few months ago. So Hawkeye, 3 are in the ICU now. That's a little higher count than what we've been seeing. So any concerns about the trend on the ICU side?
You know, certainly we saw 1, and then there was 2 on the ventilator, now 3. We know that the patients that we have right now that we are counting are here because of COVID. They've been tested because of COVID, whereas before we were testing everybody that was coming in the hospital, so we know that these active cases are really having something to do with COVID. You know, it is concerning. Hopefully we can start to see now, although it's one day compared to yesterday or Monday, hopefully we can see a trend of active infections in the hospital going down. We know that cases nationally have really kind of plateaued. Some days, if you look at Washington Post, for example, there'll be an increase. Some days there'll be a decrease. But again, there's not that steep curve that we saw before with Delta and Omicron. So.
Yeah, and now the FDA has recommended that both Pfizer and Moderna pivot to try and be ready for B4 and B5, which have turned out to be the more dominant strains finally. And thoughts about that, because it looks like both Moderna and Pfizer are going to have to tinker with their formulations just a little bit, because they were ready for Omicron, but now they're being asked to go to B4 and B5.
Yeah, you're exactly right. They were studying Omicron, so I think that's BA1. That is gone now. That virus is gone. We know the dominant ones were the BA.1.2.1, but as you said, we know BA4, BA5 in the United States is increasing. We know it's increased to become dominant other places as well. Interestingly, that FDA group, or that independent group that voted for that, it was 2 dissenting votes to, I think, 19 positive votes to do that. One of those votes that dissented was Paul Offit, who is one of the major leaders and has been in the vaccine. And I think, he brings up a good question, and things that I thought about as well is, what do we have and what do we understand about if we use a new spike protein, i.e. from Omicron or BA4, BA5, how will that actually add protection to us against hospitalization, severe disease, and death? Because what we have seen is that the current spike continues to do that very, very well. And I think, again, that goes to those areas that are unchanged on spike, those conserved epitopes, those areas that our T cells recognize to really help prevent that progression. And so I think we need some more clinical data. I think we need some more laboratory data, maybe looking at T cells, but it is a good pivot, and we'll see what eventually they want to do. Obviously, they don't have time to do the testing for BA4 or BA5 spike. Just as you said, we know Moderna and Pfizer have been using the Omicron spike, the original one. So we'll kind of wait and see what happens, but they did recommend that it will be a bivalent or a 2-spike vaccine moving into the fall.
It'll be interesting because, first, to your point, they did their clinical trials with BA1 or Omicron, and now they're going to be asked to do the actual viral thing without doing trials. I think they won't have time to do the trials, so they're going to pivot. They already started manufacturing the other vaccine, which they're not going to use. They're going to use the ones with BA4 and BA5 in it. I believe that's going to be safe because they've done the BA1 spikes. I'm not worried about that. So I think it'll be, and it looks like late October, early November. That booster shot, and I think it's so far they're saying 1 shot, not 2. So it looks like they'll be doing a booster shot for BA4, B5 in late October, early November is the time frame.
Yeah, absolutely. And I saw also in some of the, again, but have been in contact with somebody who's peripherally involved with one of those independent FDA groups, was looking at some modeling. And from one of their slides on modeling, it does look like maybe late October, November, there could be an increased surge. Again, modeling is just what that is. It's modeling, it's a prediction, and who knows if that's true. But if that is true, we'll have to wait and see, can these vaccines be rolled out before then? Obviously, we would like to have protection as an individual and as a community through vaccination before the surge hits. But I think it will be interesting moving into, as we move into this next phase. But we do understand the deadline for identifying exactly what the formulation will be is really upon us. And so hopefully we'll have more information about that in the next couple weeks.
All right, so monkeypox for just a minute. The CDC launched an emergency activation center to combat the growing monkeypox outbreak in the U.S. as cases have hit, with 244, with 43 added over the weekend after Pride Plus. Talk to us a little bit about that. And now it looks like there's vaccination for monkeypox. It could become permanently entrenched. Hawk, what do you think?
Yeah, I think this is important. This is just a recognition that now this is an important, prominent issue, especially in some communities rather than others. Especially what we're seeing here is a lot of in that population of men who have sex with men. But let's be very clear, anybody can get this disease with close contact with somebody. And so I think it is important to recognize this, identify it as, and why, because this is so easy to stop. We also heard that within the last 24 hours, I think the Biden administration, the White House, and Health and Human Services has also announced an increase in the vaccine rollout. And so now, before they were saying, well, if you've been exposed to monkeypox, now I think they've kind of expanded the ability to get the vaccine by saying if you think you have been exposed or if you are in high risk. So there will be some rolling out of more vaccine doses. I think it's important. The vaccine is the way that we stop this. I think the reason that it's really kind of run rampant now around the globe, and I think it's 49 different countries and a few thousand cases, is because of lack of immunity. Lack of immunity because the vaccination for smallpox, that stopped in the United States about 1972. Smallpox was declared eradicated in the world, and I believe in 1980 or somewhere around that time. And so what you have now is that all those people that were vaccinated, we didn't have a lot of monkeypox. Now there are generations that have come through unvaccinated to smallpox, which also, again, protects against monkeypox. And so now we have just generations of people who are susceptible to this. Probably the best way to move forward is to continue to roll out vaccines to protect against that, roll out those smallpox vaccines. And we've seen a little bit of trickling of that now announced within the last 24 hours.
Yeah, we need a new name. You guys see any monkeypox in AD?
Yeah, we are waiting for a new name. I don't know when that will come, but
hopefully soon.
Yeah.
All right, Jess, is there another community question you had?
I do have one from Gene. He said, word is that Dr. Fauci had symptom rebound after taking Paxlovid and had to take another course. If Paxlovid does that, should patients take a second round of Paxlovid?
It's still pretty rare, Hawkeye. I mean, it's forecast to be 2 to 5% of patients can get it, and usually you're still got pretty good protection. If you get real symptomatic, then you can sometimes take a second course, but it's pretty unusual.
Yeah, I would agree with you. In the clinical trials, it was about 2%. There was I think it was a Mayo Clinic study, and again, not with our friend Dr. Poland, but he's at Mayo Clinic. But Mayo Clinic, I think in clinical infectious diseases recently, it was a smaller study, so under 500 patients, but they only recognized a rebound in 4 patients, or 0.8% of people. None of those people had severe disease. None of those people had to go to the hospital. I really significantly doubt he took a second course because that is not recommended. So taking a second course of Paxlovid, if you do happen to have rebound, is not recommended. I really don't believe that would be that would happen, and I haven't seen any news that he did.
It's unusual with Paxlovid to need to do that because you also bought more time even on Paxlovid for your immune system to ramp up. So, Jess, was there anything else you had right now?
Yeah, just maybe one more for Dr. Hawkinson. Lesko wants to know, I'm seeing a lot of vaccinated people getting COVID right now. How many of the patients in the hospital are vaccinated, and why don't we report this like maybe we used to?
Let me start with that part first. So here, first of all, the term "if being vaccinated" has kind of lost meaning, and what I mean is that if you were vaccinated and it's been over a year or a year and a half now, are you really even vaccinated anymore? We call it vaccinated. The question, are you vaccinated and fully boosted? Those we're not seeing in the hospital. We're not seeing them in the ICU. But if it's been over a year since you've been vaccinated, Hawkeye, then you may have lost some of the immunity, especially if you're in a high-risk category. Remember the high-risk categories: obesity, diabetes, heart disease, lung disease, transplant, cancer, et cetera. If you're in one of those high-risk categories, you're going to have been vaccinated and still come in. By the way, still most of the patients that are in the hospital are not vaccinated.
Yeah, I think that's exactly right. And I was reading something today that said exactly that. The vast majority of those people, even though the total numbers are much, much lower, let's be clear on that as well, compared to the pre-vaccine area or prior to boosting. We know that those people that are vaccinated and up to date with their vaccination have significantly lower risk, and overall the numbers are much less. But those people that do come in and have more progressive disease do tend to be those people with those comorbid conditions or those risk factors such as age, obesity, lung disease, diabetes, those things. We need to get that information. We used to have that information. It gets a little bit harder as we get more patients. Because it is done manually, we will try to track that stuff down. But yeah.
Well, at the end of the day, what we have to say is, look, community spread of Omicron is higher than it was during the Delta crisis. And that was last November when we had so many patients. Now, this has got in January, but we got it really high in November, December as well. So if Omicron now is, if the BA 2.1, 2.1 or whatever, if that one has actually got a higher rate of community transmission than the Delta virus did, and Delta we had like 150, 160 patients in the hospital, and now we got 22.
Yeah.
So actually, vaccination is working. And the fact is, a lot of people have now had COVID, and that helps too. The real dilemma is that if you're a long way from having COVID, or you're a long way from being vaccinated, then you're just different.
Yeah.
And so it's the whole population. It's just harder to discern, what people are now than it was back when it was fresh and we were just getting folks vaccinated.
And I think we'll just end on this analogy too. Remember, the vaccine is like airbags or a seatbelt. It won't prevent you from getting into a car wreck, but what it will do is prevent you from having those severe or suboptimal outcomes. And so that's what the vaccine does. It prevents hospitalization, reduces risk of hospitalization and severe disease.
And then on this program today, that's like the perfect example.
Yeah.
Okay, if you're just joining us, we are talking about mass casualty events and how the medical community responds to those. Our panel this morning includes 3 trauma and emergency medical experts, Dr. Robert Winfield, Dr. Ryan Jacobson, and Dr. Brian Beaver. Also with us are Lee Summit Fire Assistant Chief Dan Manley, who's also part of Mark's emergency response team, and Matt Dougherty, Director of Business Development for Lifelight, and siblings Dax and Samantha McDonald, who are on the Amtrak train with their family. So first of all, let's talk a little bit about what kind of injuries did emergency responders encounter Monday, and what kind would they have expected? Chief, let's turn to you first. What did they see when they first got there?
The information I've received from the crews that were on site were dealing with multi-system trauma, also soft tissue injuries, fractures, things such as that, as a part of the initial triage at the scene.
Matt, thoughts? Oh, Matt, you may be muted.
Sorry about that. I agree. As you can imagine, the mechanism of injury with that, and just as Samantha shared, you get tossed around when that train tipped over. And so we did see a lot of head injuries. And the other thing that happened was there were a couple of patients as the train tipped over and continued to slide along the ground, we had debris that was entering the train through broken windows and some entrapment that was happening. And so there was some extended extrication for some of the patients with severe damage to limbs and things like that who were because of the entrapment.
Yeah, that'd be tough. So Samantha and Dax, you guys, this had to be really hard to see and witness.
Yeah, I remember when I was standing up and I was looking around that there was people bleeding and just everyone got tossed around. I mean, I think that's a great way to put it. And just kind of getting your bearings and seeing that, okay, there's a little bit of blood, but everyone is going to be okay. We're going to get out, that are able to at the time. And I just remember the man that was able to help me climb my way up out of the train was actually, he had his entire face was scratched up, kind of like the side of my face. And it was very, very traumatizing to see that in person and see that actually happening in real life, because you never think of anything like this happening.
Yeah, you know, you're right. You always think you're going to be okay right up to the time you're not. Dax?
Yeah.
Yeah, I would say just I think we also were able to like hear from like once we're on top of the car, other people basically calling out for, you know, we need immediate medical attention here. You know, trying to get, you know, wave first responders down for like this call, like, because we're on top of the car, so it's not easy to actually see or even hear the people inside the cars and who needed, like, you know, the most immediate medical attention. So it's basically you're on top of the car, you're kind of trying to wave down first responders are just coming over and, hey, we have someone in here who, you know, they say they're bleeding really bad and if they need, you know, medical attention as soon as possible. Yeah, that was the other thing too, is it just like the amount of people, like, I think, you know, especially when the first responders were just getting there, you know, there were more people. And also too, just the fact of, you know, how are you going to get to these people? I you know, we kind of left the scene before we saw, like, you know, some of the full like extrication processes begin, but yeah, you have people all the way down the bottom, these like, you know, 10 feet deep, you know, in these train cars. And you know, just the challenge of that was just scary to even think about. You know, shout out to all the first responders who were out there and making it happen to reach those people, which I don't even know how you get into those train cars and start, you know, providing aid.
Isn't it amazing how much training these guys have had? And I was listening to Chief G talk a little bit. You've been to a course, I think it was at Texas A&M, about Amtrak train derailment, so people can actually be ready for just this kind of event.
Yeah, that's outstanding.
Yeah. Chief, talk to us a little bit about that course.
It's a great opportunity. We've been able to host some of those classes within our region as well. And just to be able to learn about the potentials created because of the mechanism of injury of a train in motion, derailing, the structural components of a train. Not a lot of moving parts, and so those challenges about being able to access a train on its side or maybe at an angle because of how the car is positioned, it really creates some unique challenges for us. The other is a situation occurring in a remote area such as this, being able to access using a variety of things such as all-terrain vehicles, pickup trucks, other mechanisms to be able to move victims from the area of the event to another casualty collection point to be able to do more detailed assessment and then to complete treatment and transport of those patients.
So one of the things we're really proud of here at KU is that we are a nationally ranked level 1 trauma system and hospital here at the health system. And I bring that up because there are different kinds of designations that are out there. But we focused a number of years ago to be ready for a mass casualty event and to have prepared ourselves for this and to be a level 1. Talk to us a little bit about what those different rankings mean, Rob, and how it affects us.
Yeah, so I think one of the things people have to understand is that lots of hospitals call themselves trauma centers, and depending on the state that you live in, your state can designate you as a trauma center. And in Kansas, we have verification, and that verification goes through the American College of Surgeons for level 1 and level 2 trauma centers, which are the highest level of care. In Missouri, those are all done by the state, although hospitals can undertake the additional step of undergoing verification by the American College of Surgeons. The difference between the levels, in Kansas we go levels 1 through 4. Level 4, you can imagine, is a hospital with the resources necessary to stabilize and then transfer a patient out. A level 3 includes part-time general surgery coverage for potential surgical injuries, but that coverage is inconsistent, and so the hospitals again may need to stabilize and transfer. Level 2 and Level 1 centers are equivalent in the eyes of the American College of Surgeons, with the exception of one thing, and that is that the Level 1 centers contribute resources to research in the field of trauma. And so we're fortunate for 20 years now to be a Level 1 American College of Surgeons verified trauma center. We're the longest standing American College of Surgeons verified trauma center in the region.
Yeah, and that, I think we're all proud of it, guys. We work hard to maintain that, right?
Of course. Absolutely.
Any thoughts?
Well, I think it's nice having a resource locally in the region that is capable of having that. So I mean, we're blessed in the region, in the Kansas City region, to have resources to take care of people in these kind of times. So it's just reassuring.
So after the initial triage is done, people are taken to the nearest hospitals, and I'll ask both to start with our guests. But how do you guys determine what hospitals to take people to? Chief?
I'll start out. The system that we work under, we have a what we call a time critical diagnosis system within Missouri, and so it's being able to identify specialty care capabilities and then to be able to transport patients to those facilities in a certain time frame. So we've heard about in trauma services the golden hour. If we have somebody that's critically injured in an incident, then we want to try and prioritize those patients that need to get in for that surgical intervention right away. And so that's where Matt's team, the helicopters, come into play, especially in a rural setting, because then what we do is we prioritize transporting those patients to the trauma centers in the state, as was mentioned. Part of this incident specifically is that we had Dr. Carney with Kansas City Fire. She also happens to be the state medical director on the Missouri side for emergency medical services. She was in communication with Dr. Kokenauer from Columbia and some of the other trauma surgeons to be able to talk about that load balancing. And then we work with the helicopters through that communication system to determine the destination for those patients in that situation. The lower acuity patients, then we try and either transport them by ground ambulance if they're a higher acuity patient that needs that additional definitive care, or we may use buses to help transport the lesser injured population or patients so that we can make sure that they get a full evaluation, possibility of them getting redirected to a tertiary care center for that more advanced treatment should something arise during their evaluation.
Matt, how do you decide who gets on a helicopter and who goes by ground?
The incident command structure at the scene really helps with a lot of that, and as a part of the triage system as they're going through and evaluating the patients and determining who has the best chance at survival, given that they can receive the critical care and given that they can get to a trauma center and an OR as quickly as possible. Those patients are prioritized. And as Chief Manley said, the smaller injuries or the non-life-threatening injuries may be taken by ground ambulance or by a bus even to a smaller local hospital, regional hospital that has the ability to take care of those minor injuries while we prioritize those critical injuries, transporting them by air to the Level 1 trauma centers.
Yeah, Chief, and just a shout out to you. You also got the 2022 Leadership Award from the Metropolitan Area Regional Councilor Mark for your great work and your service to Mark. And Mark is celebrating 50 years of its service this year, so congratulations to you. Jess, what are the questions we have out there?
Kathleen is, if being vaccinated almost a year ago may not mean that you're vaccinated, why are we not recommending that second booster for everyone?
I think we're trying to tell most people to go get that second booster.
Yeah, so currently, if you are not immunocompromised, you are recommended to have a second booster if you are 50 and older, and that's still a little bit younger than where we see the highest chance and risk of hospitalization. And I believe the reasoning there is that people 50 and older a third or more of those people have comorbid conditions. So right now it is only recommended for that age group. Why is that? Because we have still seen very good effectiveness from this vaccine immunity at keeping people out of the hospital, keeping people from going to the ICU. These are internal debates and some external debates that the experts who are making these recommendations continue to have. These will be part of what happens and when we get the new recommendations, probably for the fall, which will probably be coming up probably in the next 4 to 6 weeks.
I think that's right.
But again, we've also heard that there's dissent in even the FDA group that recommended and wanted to go to a bivalent vaccine, as we heard within these last 24 hours. So right now, the vaccine effectiveness, if you are vaccinated and have had your booster, if you are below 50, then you are still very well protected against hospitalization, severe disease, and death.
And I think that's the key. It is really that focus on those two things,
Yeah.
severe illness and death. And what we know is the biggest rise in the disease categories are those who are over 65. And so that's why they went down to 50, because of your point, a lot of chronic disease in people at 50 and less. I'm one of those. And so folks are 50 more, and I'm not less than 50. I wish that was still true. But I think that's really the key, is that's where we're seeing the biggest rise. That's where we're saying go get that second booster. And everybody will get a booster this fall, I expect. Jess?
Dr. Stites, we get a lot of questions about timing out when to get that booster. Kathy says, my mom will be due for her 5th booster in mid-August. Does it make sense to get the booster or just wait for the vaccine, since she's not, the new vaccine, since she's not at risk?
I'm not sure there's actually a recommendation yet for a 5th booster, unless you have had a bone marrow transplant or an organ transplant, and then yes. But other than that, Hawkeye, I don't think there's a recommendation yet for a 5th
I'm not
booster.
sure. Even for those immunocompromised, again, you should get 3 doses for that primary series, and then a first booster, and then a second booster, which is a total of 5 doses.
Yep.
But otherwise, I would not delay. And if you are due to get a booster and it's recommended you fall into that category, go get it now. You can certainly always get the new formulation when it comes out. More than likely, it will be out in a few months. At that point, enough time has passed where you would be okay to go get that.
Yep. Jess,
Last question. Last question for our panel, or a couple of folks on our panel. Can you speak to the issues, really, and the challenges of having to respond to varying ages or people of different abilities? You might be in some of these mass situations, toddlers and people with disabilities or elderly. How do you manage that challenge?
All right, guys, how do you respond to that challenge? Go ahead.
A lot of it goes to the training. Our helicopter crews and ground ambulance crews don't necessarily know what they're going after at any given time. And so ongoing training, when you become a paramedic, you become an EMT or even a first responder, your training's not over then. We go through hours and hours of continuing training throughout the year to hone the skills and practice, because when you respond to an incident like this, as you said, you could have toddlers, you could have seniors, kids, and it could be trauma. You could have stroke that they could be responding to. It could be cardiac related issues they could be responding to. And sometimes it's a combination of both, one caused by something else. And so that ongoing training is critical for EMTs, for paramedics and first responders, especially when they are in those rural communities where the transport times are so long. In this case, a ground ambulance transport to a trauma center could have been 2 hours. In some cases, and even by air, we were looking at 28 to 39 minutes, depending on whether we were going back to Columbia or Kansas City. And so that's a long time to be caring for a patient. And we have to have the equipment on the ambulances, we have to have the resources on the ambulances, and then have the skills for those EMS providers.
All right. Well, guys, I want to say thanks to everybody for being with us today. We're going to get final thoughts from our guests. And actually, I'm going to start with Samantha and Dax. First of all, Samantha, just really quickly, does this make you want to go to medical school more or less?
I think, if anything, this kind of reignites the fire for being a part of the teams that are able to come out there, and we're on scene and we're just absolutely outstanding. I mean, I remember a nurse at Moberly Hospital, her name was Jillian, and she held my hand, and she was actually called into work that day because to help with everyone that would be coming into the hospital. And I can't thank everyone enough for everything. So yes, it does, absolutely.
Well, and thank you. I'm glad you're interested in the field. I'll just say to you, I've had the greatest job ever, and I love what I do. So, not Matt, sorry, your brother. Jeez, Dax. I should remember that's a Star Trek character, just so you didn't know that probably, but Dax.
Yeah, I think I just, again, so much, I'm so thankful for the entire community of Mendon who came out, went to the high school, and there was they already had drinks and food and water. They had the whole gymnasium set up. Yeah, I was just, the whole town basically came out. We saw, I think, people, farmers who drove a tractor through a field and was running toward the train, to help people. It was just so incredible, I think, to see the whole community come together. And everyone in this small town basically came out and were coming with crowbars and ladders and everything they could carry to help people get out of the train. It was just, it was incredible to see just everyone pulling together to just help with this disaster. That was my biggest takeaway was just how important community is and how amazing that community is, that everyone was there and helping people. It was wonderful.
America together. I love it. All right, Dr. Winfield, final thoughts.
I would just say, I think, one, the level of coordination involved, people can see what an incredible effort this was by people at multiple different levels, again, from the community to the responders to the trauma centers. That doesn't happen by accident, right? This involves years of preparation for things like this. While we all want to hope that this won't hit our community anytime soon, all we have to do is look at the news each day and we see incidents where multiple people are injured in a given situation. And so we're, of course, preparing in the trauma center. Our folks at MARC and other analogous community agencies are doing the same thing. But your preparation can begin at home, too. If you go to FEMA website, they'll give you advice for how you can prepare for natural disasters or disruptions to your community. So be prepared. These things do happen. Again, whether natural disaster, train derailment, mass shooting, these things are happening in communities around the country on a daily basis. And so it's up to all of us to be prepared for the inevitability of this occurring.
All right. Dr. Beaver.
I just want to give a shout out and kudos to those first responders that were on the scene, as well as our flight crews and everything, to do what they did that day. They're out there prepared and ready to respond at a moment's notice, and they never know on which day that they go to work an event like this might happen to them. And so the ability to go into a difficult environment in a very remote area and take care of the number of people that they did was really quite impressive.
It is impressive, especially in the fields like that. Dr. Jacobson.
I'll have to do the same and give a shout out to the responders. I think it's so hard to get a real feel for how hard that job is as a first responder. Remember, you can't drive fire trucks frequently on soft ground. You have to take your equipment and bring it to the site. Firefighters are wearing bunker gear, full protective gear. It's hot, it's outside. The EMTs and paramedics are carrying their medical bags and gear, which could weigh 10, 20, 30 pounds, and bringing it to the site. They're climbing structures. They're doing things in dark environments. There may be power lines involved in certain situations. It's just a really unsafe and unstable environment, and they have to deal with it. They pull up to these scenes, and they manage to get through it through incident command and their training. And so I just think it's so hard. The job is just so hard. So great job.
It is a great job, and we would be lost without them. Matt, final thoughts from you.
Again, I echo those thoughts. And remember, these are tiny EMS agencies and volunteer fire departments, and the credit to them and to the entire community for coming together and responding so quickly. The assets from the entire region, they were very near to running out of local supplies almost immediately, and we had trailers coming in from other fire departments and districts further away with the additional supplies that were needed to respond to that and be able to appropriately care for the patients. So the coordination, but also, again, seeing everyone come together in divisive times, and when you see so much angst and so much bad news, it really gives a boost and gives you more faith in humanity to see people coming together, both the responders and the community itself. It was really heartwarming.
Chief Manley.
Well, I'd really like to recognize Dax and Samantha and the other passengers on the Amtrak, their ability to remain calm through the event and to work together until help arrives to be able to provide additional resources was amazing. I think that over the coming days and weeks, we'll be learning so many feel-good stories about how individuals were able to help one another and make a difference in someone else's life. And really that's what community is being able to support one another and make a difference. And so I really like to thank you both for your efforts and glad that you're doing well today.
Yeah, man, you said it, Chief. That's a great talk.
Yeah, just thank you to our first responders, our EMS out in the surrounding communities. Big thanks to our emergency responders here, our systems, our processes that we have here in our trauma bay, all of our physicians and care teams and nurses that help to do that. So just very, very thankful to be around these excellent people with excellent training and really who help save people's lives every day.
Thanks for being with us today. Don't forget you can catch our updates anytime by logging on to our Facebook page or the YouTube channel. Tomorrow, the 4th of July, is just days away, and just like fireworks, injuries shoot high up into the sky too. Ways to keep you and your family safe. We'll be back at 8 a.m. We'll be live on Friday with a very moving and inspirational story. Have a great day, and remember this: you can't unsee what you've seen. That is really true, and special thanks and hats off to everyone there, but for the grace of God go I. We'll see you all Friday.
A well-known Kansas City couple shares how they are living through a devastating and rare diagnosis.
I'm not missing state swim. I literally went, I had chemo, and then I went straight there after that.
And she slept in the bleachers when he wasn't swimming.
I did.
How their story is inspiring other patients and their families. Join us for this very special morning medical update, Friday at 8 on these social media channels.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now, everywhere podcasts are available.